I'm Tobias Carling, and I'm the Surgeon-in-Chief and founder of the Carling Adrenal Center in Tampa, Florida. And I will talk about various types of adrenal surgery and how to choose one. First of all, I want to highlight our new hospital, the Hospital for Endocrine Surgery, which is currently in construction with an anticipated move-in date December 2021. This will be a unique hospital exclusively for endocrine surgery, full-fledged hospital with operating rooms and so forth here in Tampa, Florida. And it will house the practices of the Carling Adrenal Center, the Clayman Thyroid Center, the Scarlett Thyroid Surgery Center, and the Norman Parathyroid Center. So we're very excited from that, and hopefully we'll be able to host some of you at our new hospital in the future. The 4 division leaders are Jim Norman, who runs the parathyroid practice, Gary Clayman, who runs the thyroid practice. I'm Tobias Carling, running the Carling Adrenal Center, and Dr. Jan Saksa, who you know very well, who joined us recently to run the Scarlett thyroid program. We perform 3 times as many thyroid, parathyroid, and adrenal operations than any other hospital or institution in the world, and 5 times any hospital or institution in the United States. So we're very excited about this development and look forward to present more as we're embarking on this exciting new chapter in our lives. Adrenal incidentalomas are defined as adrenal masses greater than 1 centimeter. They're discovered incidentally on a radiological exam, usually a CT scan, performed for other reasons. Patients do not have any overt adrenal symptomatology. The prevalence is low in young patients, but are usually significant. But adrenal incidentalomas can be found in up to 5 to 7% of patients 70 years or older. Of course, the biochemical workup to rule out primary hyperaldosteronism, hypercortisolism, as well as pheochromocytoma is absolutely key, but the imaging phenotype is important as well to decipher which tumors need to be resected. Most adrenal incidentalomas are lipid-rich cortical adenomas. CT scan and MRI can help define the characteristics. And worrisome imaging characteristics by itself may be an indication for surgery. Interval growth as well as tumors greater than 4 centimeters often require surgery. Of course, understanding the molecular pathogenesis of adrenal tumor disease is absolutely crucial. It's been now 10 years since we published a seminal paper in Science identifying that mutant casein NJ5, which encodes the potassium channel in the adrenal granulosa cells, when mutated leads to influx of sodium, which leads to membrane depolarization, and then aldosterone secretion and aldosterone tumors. This molecular pathological studies proved also important from a clinical point of view, since there is a genotype correlation with the clinical, radiological, and pathological phenotype, such that certain tumors tend to have a characteristic mutation. There's now been we and others have described other mutations in other genes, including the calcium channel, as well as in ATPase encoding genes. But we can now predict, even on a preoperative CT scan, what type of tumor mutation the patient will have. So for instance, patients with casein NJ5 mutant aldosterone producing adrenocortical adenoma often tend to be larger, occur in younger patients, often females with very low Hounsfield units, and often adrenal vein sampling can be a avoided in these patients. CACNAT1D and ATPase gene mutations tend to be smaller, whereas wild-type tumors tends to be more heterogeneous. We also described the molecular pathogenesis of cortisol-producing adrenocortical adenomas, which frequently harbor mutations in the catalytic subunit of protein kinase A. In our hands, the mini-back scope adrenalectomy is the preferred approach in 96.3% of our cases. We found that the operation is better, faster, typically 12 to 23 minutes in a non-obese individual. The patients have shorter length of stay, faster recovery, and a superior cosmetic outcome. So the topic of this presentation, though, is when is the mini-back scope adrenalectomy not the best approach or not the preferred approach? Well, sometimes when patients have huge metabolically superactive pheochromocytomas, a laparoscopic transabdominal adrenalectomy can sometimes be preferable. So this is a patient with a 9 centimeter left pheochromocytoma. He presented at age 37 with a 2-year history of severe headaches with mild hypotension. But 1 week prior to presenting to me, he had developed an adrenergic crisis with severe headaches, palpitations, nausea, and diaphoresis. He then collapsed at home as he was brought to an outside hospital where the imaging studies demonstrated the large left adrenal mass. He was started on a very aggressive titration of alpha blockade and then subsequently beta blockade with addition of doxazosin. But as you can see, his 24-hour metanephrine and normetanephrine was more than 100 times normal range, so it was a super active metabolic tumor. And despite being on very high aggressive blocking, he, even in the clinic, his blood pressure fluctuated from 200/95 to 125/80 as we were seeing the patient. And because the induction of anesthesia made his blood pressure go to close to 300 systolic blood pressure, we found that doing this laparoscopic transabdominal was advantageous. So for very big tumors, certainly laparoscopic approach with and without a hand port is helpful. Obviously, for if there's a concern of direct invasion from an adrenocortical carcinoma, an anterior transabdominal approach, I would often start these operations laparoscopically, and then dependent on intraoperative findings for large tumors, meaning greater than 10 centimeters, either add a hand port or convert to an open operation. Also, for patients with pheochromocytomatosis, an open transabdominal operation is required. This is a patient who is 55-year-old female. She had previously had a left adrenalectomy in New York for a left pheochromocytoma, but they described spilling tumor cells during the operation, and pheochromocytomatosis then is implantation of these tumor deposits throughout the abdomen. Here you can see an MIBG scan showing uptake in the left adrenal bed as well as in the left paracolic gutter. So this shows a represented CT scan showing the mass with the arrow, number of clips as you can see, but within the left adrenal bed there's residual pheochromocytoma tumor cells as well as paracolic gutter. So this operation then required a open approach because during the operation we identified more than 30 tumor implants that are labeled here with arrows within the left adrenal bed along the omentum and onto the spleen, and we cleaned out this completely. And this shows the completed resection where the aorta, the left kidney, the left renal artery, the left renal vein is completely skeletonized, where all fibroadipose tissue together with the omentum and the left adrenal bed has been cleaned out, providing then a biochemical cure for this patient with pheochromocytomatosis. Another example of a patient where open surgery is required is a patient with metastatic retroperitoneal paraganglioma due to a germline mutation in SDHB. This is a patient who initially presented with constipation, ultimately ended up getting a CT scan that showed this large mass in the retroperitoneum anterior to the aortic bifurcation. A general surgeon at the outside hospital had then taken the patient to the operating room for a laparoscopic biopsy, which is obviously a bad idea because this could easily have been diagnosed with other means. But nonetheless, unfortunately, the patient had an excisional biopsy that led to profuse bleeding, but fortunately survived this episode. She then presented to me where we obtained this CT scan as well as an MRI that shows this 8 centimeter retroperitoneal paraganglioma with associated lesions that were lymph node metastasis. And as you can see on this MRI of the L5 vertebral body, it shows tumor deposit in the L5 vertebral body, and in fact the patient had some neurological symptoms due to cord compression. So in this particular case, we performed an open transabdominal approach where the exposure reveals the infrarenal aorta. So you can see the inferior mesenteric artery that was going straight into the tumor. So the primary tumor as well as those associated lymphadenopathy was resected. Then on a subsequent operation through a posterior approach, the orthopedic surgeon resected the L5 vertebral body and provided stabilization of the spine, and the patient then did quite well for a number of years after the operation. And this shows the completed dissection where the infrarenal aorta, the aortic bifurcation, the right ureter and the left ureter, both which have been stented preoperatively, has been completely cleaned out. And again, this represents an example of when open surgery is needed. So in summary, our approach for adrenalectomy is the mini-bag scope adrenalectomy or the posterior retroporoscopic adrenalectomy in 96.3% of the cases. However, open surgery, meaning or laparoscopic transabdominal surgery with and without a hem port, is sometimes used for very large tumors greater than 10 centimeters, very active pheochromocytomas, or patients with pheochromocytomatosis or metastatic paraganglioma. So I thank you for your attention, and I hope you have a great rest of the meeting. Thank you.